Hello, my name is Jenna Halpert, and I am a medicine ICU nurse that is in the acute care adult gerontology tract for the University of Kentucky's DNP program. And this is the educational intervention for my DNP project entitled Increasing Adherence to Protocolized Diuresis for Deresuscitation of ICU Patients by Increasing Nursing Knowledge and Confidence. The learning objectives for this intervention are to determine why critically ill patients are over-resuscitated, to understand complications of over-resuscitation and fluid overload in critically ill patients, to describe the signs and symptoms of over-resuscitation in medicine ICU patients, to identify benefits of deresuscitation, to understand the nurse-driven diuresis protocol and how to integrate it into nursing practice, and to determine which patients qualify for the nurse-driven diuresis protocol versus single-dose or IV drip diuresis or even renal replacement therapy. So why is resuscitation important? Patients are routinely and aggressively fluid resuscitated to help improve hemodynamics and organ perfusion in the ICU. Adequate fluid resuscitation dramatically decreases mortality rates for ICU patients. And currently there is a lack of standardization to identify fluid overloaded patients with no specific recommendations for transition from fluid resuscitation and fluid removal. There are several complications of over-resuscitation in ICU patients. Positive fluid balance by day 3 is an independent risk factor for 30-day mortality. Over-resuscitation decreases renal function and increases acute lung injuries requiring prolonged mechanical ventilation. Additionally, over-resuscitation can cause acute respiratory distress syndrome, pulmonary edema, acute heart failure and diastolic dysfunction, impaired bowel function, tissue breakdown, and delayed wound healing. With the number of HAPIs that the medicine ICU has had recently, we definitely don't want to increase our risks for tissue breakdown and delayed wound healing by having extremely over-resuscitated patients. Because fluid balance is not always precisely calculated, a patient's clinical exam and hemodynamic status together is a more accurate reflection of volume status. Vital signs alone are not reliable as endpoints for resuscitation because they do not indicate ischemia at a cellular level. Additionally, central venous pressures and pulmonary artery pressures do not accurately provide information about fluid status. Other indications of fluid overload are lactic acid, pro-BNP, renal function panels, and electrolyte levels. So there are several benefits of deresuscitation in ICU patients. These include decreased ventilator days, decreased length of stay in the ICU and total hospital stay, reduced mortality rates, and additionally, recent research indicates that IV push diuresis deresuscitation is just as effective in the majority of patients as continuous furosemide or Bumex drips or hemodialysis. The MICU diuresis protocol is a nurse and pharmacist-driven protocol developed by medicine ICU pharmacists Brittany Bissell-Turpin, Melanie Lane, Melissa Thompson-Baston, and Alex Flannery in conjunction with nephrology and pulmonary critical care physicians. Its goal is to improve the fluid balance post-shock in order to improve clinical outcomes with a simplified protocol that utilizes commonly evaluated bedside parameters. Inclusion criteria for the diuresis protocol include non-pregnant patients verified via serum HCG tests. They must be 18 years or older admitted to the medicine ICU, and they must be receiving either mechanical ventilation or non-invasive ventilation such as BiPAP or high-flow nasal cannula with a net positive or net even fluid balance or signs of fluid overload on chest x-ray or physical exam. These patients must also not have been administered any vasopressors or bolus crystalloids within 12 hours unless they are in cardiogenic shock. And norepinephrine must be less than 0.05 micrograms per kilogram per minute. There are significant exclusion criteria for the diuresis protocol. This includes chronic restrictive obstructive neuromuscular chest wall or pulmonary vascular disease resulting in severe exercise restriction, secondary polycythemia, severe pulmonary hypertension or respiratory dependency, amyotrophic lateral sclerosis, or a neuromuscular disease that impairs the ability to ventilate spontaneously, such as a C5 or higher spinal cord injury, Guillain-Barré syndrome, or myasthenia gravis. Another exclusion criteria is a nephrology consult for acute renal failure, which is defined as serum creatinine 3 times the baseline, or less than 0.3 milliliters per kilogram of urine output for the last 12 hours, a serum creatinine greater than or equal to 4, or receipt of renal replacement therapy. Additionally, acute treatment of any of the following excludes patients from receiving the diuresis protocol: diabetic ketoacidosis or hyperosmolar hyperglycemic state, rhabdomyolysis with a creatinine kinase level greater than 5,000 units per liter, or treatment of suspected hepatorenal syndrome with failure to respond to an albumin challenge and withdrawal of diuretics for 48 hours in the first 72 hours of active treatment, including albumin and vasopressors or midodrine and octreotide. As you can see, this is the current algorithm for the diuresis protocol, which I will be explaining and elaborating on the next few slides. As this protocol is both nurse and pharmacist driven, the pharmacist has several responsibilities. The daily fluid goal is determined during morning rounds and is typically 1 to 2 liters net negative. The pharmacist discontinues maintenance fluids, and IV drips and medications are either max concentrated or converted to oral formulations as appropriate. If the patient was unresponsive to diuresis during their current ICU admission, the initial dose will be doubled. And additionally, if furosemide has not been administered during their current ICU stay, the pharmacist will dose based on their GFR. As stated above, the daily goal fluid balance is determined during morning rounds by the team in pharmacy. Shift goals are determined by taking the daily fluid goal and dividing by 3. For example, if the daily fluid goal is net negative 1.5 liters, the shift net goal will be 500 milliliters over 8 hours. The primary RN is responsible for documenting urine output every 2 hours and patient intake at least every 8 hours. Ideally, both intake and output are charted hourly, as they are with CRRT patients. BMPs are drawn every 8 hours, and RNs should monitor for electrolyte disturbances and replace as needed. Additionally, it's the responsibility of the bedside nurse to let both pharmacy and the team know if there's been no response to diuresis within the first 2 hours of administration. We also need to notify the provider if the dose is not given and why we decided not to give it. If there's no response to the initial dose, the second dose of Lasix will be doubled. Pharmacy may also consider combination therapy with either 10 milligrams of metolazone PO or 500 milligrams of chlorothiazide IV if there's no PO access. The 10 milligrams of metolazone needs to be administered about half an hour prior to administration of the IV diuresis. The primary nurse is also responsible for monitoring for hemodynamic instability and notify the team if the patient has had a supratherapeutic response, so that if the diuresis was too successful. So if the goal is net negative 500 for 8 hours and they're already net negative 1.5 liters 2 hours into administration of diuresis. So when should diuresis be held if we're using the diuresis protocol? RNs should hold diuresis if there's a 25% rise in creatinine within 24 hours, or if the daily net volume is already 1 liter over the goal. Additionally, if the serum bicarbonate is 40 millimoles per liter and their pH is 7.5, diuresis should be held. If potassium is less than 3 millimoles per liter after replacement, or if sodium is greater than 150 millimoles per liter. Additionally, if our MAP goal is less than 65, unless we have a lower MAP goal ordered, or if the heart rate is 150 beats per minute that's sustained. As stated in the last slide, the pharmacist and the team should be notified if diuresis is held. I really appreciate you all participating in this educational intervention for my DNP project. If you could, please take the post survey that I'll be sending out soon. Thank you very much.